physician-computer company. PCC empowers independent pediatricians, streamlining daily operations and improving financial stability. A trusted pediatric partner for 40 years, we offer award-winning support, personalized training, seamless data transitions, and practice analytics. With inclusive pricing, a lively peer community, and a free annual users conference, you can focus on what matters the most, your patients. Explore more at pcc.com. That is pcc.com. To this episode of the podcast. This is your co-host, Dr. Herb Bravo, and with us is Dr. George Rogel, your co-host from Long Island, New York. Today we have the pleasure of hosting Dr. Bill Long from Columbus, Ohio. Bill manages and leads a supergroup in Columbus, Ohio, with 6 offices and 30 clinicians, including mental health. And he also is the leader and president of CPP, Children's Practicing Pediatricians Medical Association, which is a chamber of commerce for pediatricians in Columbus, Ohio, and it is also a national GPO with great rates on vaccines for pediatricians. The number one thing that worries Bill is the culture of the organization, and he spends a significant amount of his time mining and making sure that the culture of the organization is healthy. I hope you enjoy this episode. Hey, George, great to see you. You're finally back from Europe.
I'm in the office doing my thing. I just finished with a patient, so now we're ready for a podcast.
So we have Dr. William Long, who is the leader of a supergroup in Columbus, Ohio, and also the leader of a pediatric medical association affiliated with the Children's Hospital in Columbus today. It's a pleasure to have you in the show, Dr. Long. How are you?
I'm well. Thanks for having me. And please call me Bill. That's
great.
Thanks.
Bill, why did you become a pediatrician?
It was a journey. I wanted to be a doctor since I was 11 years old, but I thought I was going to be an ophthalmologist at first. And as I got older and saw older people get older, and I decided I want to focus on taking care of kids. And I entered medical school thinking I wanted to be a pediatric subspecialist. But as I did my medical school training and realized that, yes, I still want to be a pediatrician, but I wanted to keep my options open. So I really wanted to be a pediatrician because I want to help kids, obviously, like most of us do. And I want to be more on the preventive side. So too many adults with complications of diseases that I think could have been avoided. That's why I'm really driven to pediatrics. I wanted to try to stop those things before they happen.
It's hard, isn't it? When you see the 40, 50-year-old with a massive heart attack and they haven't taken their Lipitor, they don't control their diabetes, they don't control their high blood pressure, and then they're crying like little babies at 2 a.m, save me. You didn't want to save yourself. Now it's a little too late.
Yeah.
It's a sad. Now you have a big group.
Wow.
Out there. You have 6 offices, almost 25 clinicians, including mental health.
That's a lot of cats to herd.
Yes, it is.
How do you manage all of that?
That's a great, so this group did not form from multiple separate groups. When I started, it was 6 doctors and I was hired to start a satellite office, about 8 miles from the original office. We just started growing organically and our practice got bigger and bigger. So yes, we have 5 traditional sites, and one of our sites is actually a school-based clinic that we just opened up this year. But as we grew, when we first started, we did like most groups do. Hey, all the doctors got together, we made the decisions, and then the owners made the business decisions. And then as we got bigger, we realized this is not working at all. Trying to get 19, we were 19 at that time, trying to get 19 doctors to sit down in a room once a month and agree on stuff, impossible. Oh, yeah. So we actually had a firm do an analysis of our practice and come up with a leadership structure so that we now have a board. Like we've got a CEO and a COO, and we've got an executive director who's essentially our operations manager. And then every site has representation from one of the owners of the practice. And that is the board that makes the decisions of the practice, the day-to-day decisions and the bigger decisions. The only thing that the owners, and there's 20 of us who are owners, decide on is basically how we pay ourselves and big payouts and budget and things like that.
Oh, wow.
A lot of owners, 20, and there's 20 owners and 25 clinicians.
Yes. If you add our behavioral health folks, we have 31 clinicians in total.
Wow.
And we are currently talking with other smaller groups in town, say, hey, maybe we should get together to be a larger super
Yeah.
group. And that would, if everybody else, there's only about 6 other practices besides us who are totally independent left in town.
Now I ask, why do you have 6 locations?
Right. Yeah. So it all started with our location I work at, and it just took off because we found a great place with young families moving in, and there was no competition, and it kept growing and growing. So one of our locations is actually a satellite of our first satellite location because we just didn't want, it became so big. We have 7 doctors working a day in that office, and we didn't want to make it bigger. So we just decided to make a satellite office, and it's just something that we've gotten good at using some economies of scale. We do have staff that go between offices. We did add one practice. It was a solo practitioner years ago, back in the late 90s. And so that was the only practice we acquired. And then we just saw opportunities in areas of town that at the time there was nobody else at, and they were growing areas of town. And we just had the capability to build more sites.
I guess if you build it, they will come for sure.
Yeah, we found that's true.
That happens. But so you, in one office, you have 7 physicians working at the same time?
Yes, on Mondays and Tuesdays. Yeah.
That's interesting. 6 footprints, 25 clinicians doesn't seem to be enough, I think.
Not every, the one site is bigger. The Pickerington site is where we have the 7 physicians. On most other sites, there's anywhere from 2 to 5 physicians working a day.
Okay.
And we just hired 2 nurse practitioners as well.
And do you guys have, each office has its own phone system or is that centralized?
It's centralized. Half the offices have one phone, half the offices have the other phone. We do have some centralization.
Yeah.
Our referral team is all centralized. Our billing team is centralized, as well as our,
All right. Yeah. It
all
looks like
those.
you incorporated mental health within the group. How did you do that?
So we lucked out and got a hold of a psychologist who had done a similar thing with behavioral health integration in the Chicago area. And she wanted to move back home, which was Columbus. And she had already built a program in Chicago and was looking for a practice. So we hired her as being our first clinician. She started seeing patients in the office, and she's our employee. And obviously, as you guys know, the demand for behavioral services is pretty high. So she got busy very quickly, and she hired more. And since she had developed the program before, she knows who to look for, what type of clinicians that can do this work,
Yeah.
and how to staff it and to make money. So we've got now 2 psychologists, 4 master's level social workers, and they see our mental health patients.
Yeah, but usually with the behavioral health department,
Mhm.
getting the patients is the easy part. Getting the
Yeah.
clinician is not too complicated either. It's getting the money to come back in to pay all this stuff. That becomes a little bit of a hiccup. How do you guys
Yeah.
make that work?
Our local ACO that we contract with for our Medicaid population does credentialing, and getting these providers credentialed through that ACO has made all the difference as far as us getting paid.
Oh,
So we
okay. You're not doing
actually,
it as an individual group, you do it as a bigger group. That's what
yeah. So this credentialing process, we get paid fairly well. And looking at the latest numbers, we're probably going to end the year in the black with our behavioral health program.
I hope so.
With the psychologists, the margins are a little slimmer, but with the master's level folks, we're definitely not losing money.
Yeah.
Wow.
I mean, the Medicaid lines of businesses, they want the behavioral health. It looks like, so I think they're willing to work with practices that want to show an interest. What are some of the biggest business challenges that your groups can face?
I think anybody staffing, hiring and retaining good staff, that's
Right.
always a struggle. And
Yeah.
yeah, it's been worse since COVID started, but
Yeah.
I see that's one of our biggest challenges. So we've done some consolidation. There was a time there we had to turn away patients because we didn't have enough staff to work with doctors.
Yeah,
And
that's the worst part, turning away patients. That means you have a good problem.
yeah, yeah.
We had that problem with, we used to have 3 footprints, and the phone systems were separate. So the lines were calling directly to the offices themselves. If somebody called in sick at the front desk in office A, you had too many people in office B. You either had to move a body
Mhm.
or you had to work short. And the same thing happened with the nurses. And once we got the computer systems, we centralized the call centers. We moved all the business and all the administration, all the phones outside of the 2 offices. So inside the offices is just medicine, just clinical stuff. And with our EHR, you can make an appointment to any office. And the call center is really
Right.
close and they know what's happening and in communication with the office. It's not like the big systems where the call center is in Florida.
Oh, yeah.
And they could have a direct call to the office if needed. Any thoughts, Dr. Bravo?
It's a very large operation.
Yeah.
How many days a week do you spend managing?
I'm essentially 2 days a week in management. I also do administration for our local children's hospital, but that's flexible time. So I'm doing 1.5 to 2 days of management within the practice.
There's stuff to manage. Yes.
Yeah, we
Yeah, the
had
doctors, they don't, give you any hard time saying that, you're doing paperwork and you're not pulling your weight?
no, not really. A little bit that,
Yeah.
they look
They
at
get
what
you.
they're paying me and which
Yeah.
is not anything near what I could be seeing patients, right?
Yes.
But,
Yes.
they see that as overhead, my salary. So, maybe I think maybe we should join a bigger organization. We don't have to pay our anyone from our practice to lead, but
And then you'll pay somebody else a lot
you're
more.
gonna pay, yeah, you're gonna pay somebody. It still goes to your overhead regardless. But,
Yeah. I'm
uh
curious to see, what do you think is the future outlook of the specialty of pediatrics? How does that look like to you? How do you envision it?
That's a great question. And I think what's going to change, obviously, I listen to your podcast on urgent care, like the infectious disease stuff isn't there like it used to be. I think you were really going to have to focus on preventive care and mental health and more chronic problems. I think with the advent of telehealth, co-managing chronic patients with Crohn's disease and other chronic diseases that
Right.
might be traditionally managed by subspecialists, that a lot of co-management. I see the increased use of physician extenders, either PAs or NPs, to see a lot of what we used to call the bread and butter of pediatrics. Or another model I see that potentially is using them as, meaning the physician extenders, as your subspecialty follow-up, like they do your ADHD med checks or they do your asthma med checks. I think the folks who do that work can become specialized in one area. They do a really good job. And I think a lot of the larger children's hospitals are going to that model, that most of chronic care follow-ups are done by physician extenders.
How about orthopedics?
Same, at least in our area. A lot of the fracture follow-ups are done by physician extenders, and we don't do a lot of orthopedics in the office. So we'll do strains and sprains, but beyond that, we're not doing anything within the office ourselves.
Yeah, I think that's an opportunity, right? People always going to break something, especially children.
Sure. Yeah.
You know,
Mm.
the interesting thing is, her, remember when we first started practicing, it was always on a Friday night, kid falls down, cuts his chin, you got to call a plastic surgeon, and they climb in a tree, fall down, breaking the wrist, buckle fractures, torus fractures. I haven't seen a buckle fracture like in ages. Kids don't climb trees. They don't fall down. They don't ride bikes. They don't fall down and break their chin. They're playing it. You'll get the tension on the thumbs from the video games, but they're just not out there anymore.
I think also because of the urgent cares and access to emergency rooms, they don't think of the pediatric office as a place that they go to.
Yeah,
So
that's
yeah,
but the culture has always been established as call us.
yeah, but I think a mom with a baby that has a gash on her chin and is bleeding like crazy gets in the car and drives to the emergency room in a panic. And that's it. She's not
Yeah,
thinking anything else.
they used to. We used to have them come to the office, call a plastic surgeon, say send them to this ER and take care of it. I was of the generation where you actually stitched, so I learned how to stitch at Jacoby Medical Center, and I knew that the practice stitched a lot. So I got really good at it before I came here. And then what happened? The glue came out, the Dermabond, and then everything disappeared. That was a wasted procedure, but whatever. You move on.
Yeah. Doing stitches in the office is not profitable. It takes so
No,
much.
it's not profitable.
Yeah, it's not. We found that out as well.
Yeah, but if you do a visit and evaluation, you call a plastic surgeon and you tell them, and now you send them a picture. They decide what they want to do, where to send them. Out here on Long Island, they even have this, it's called Dr. Stitch, where they have a GPS locator of their plastic surgeons. And depending on where the patient is located to a plastic surgeon around some hospital, they'll tell you, send them to this hospital
Pretty
and
cool.
they'll take care of it. That's pretty cool.
Bill, what is CPP?
CPP stands for Children's Practicing Pediatricians. It's an organization that was put together with the Children's Hospital and the community pediatricians. It kind of initially was to try to preserve the continuity of the community, take us over, because that's what was threatening to happen at the time back in '85 when it formed. And we've morphed into a chamber of commerce for our local pediatricians. And we now have a national vaccine buying group that has practices in 42 states. But our local group does things for our members, education, and grants resources, and works in advocacy projects as well.
And does it advocate for payment reform and Medicaid payment?
As much as it can, yes. We actually, for that part of it, one of our CPP members, actually with the staff member, is a member of our AAP chapter
The council?
committee that does that.
Yeah.
So we have CPP has a seat on the AAP committee, state committee or chapter committee that does that work.
And have you been successful in getting Medicaid to be on par better than Medicare in Ohio?
Yes, we're lucky, at least where we're at, because we contract with the ACO, which is called Partners for Kids. And for most things, we still get pushbacks on, okay, how many immunization administration charges you can do. But for most things, like for regular visits, we get about 110% of Medicare
It should be
for
across the board, but
yeah. And we do have incentives if we meet certain benchmarks, and we don't have to reach a percentage, but it's actually per patient. So for every teenager that I do a checkup on that didn't have his checkup or her checkup the year before, I get an extra bonus incentive for each patient beyond the regular fee for
Oh,
the.
nice.
they seem to have it under wraps. I wish New York would be like that because New York is terrible. Less
Really?
like 60-70% of Medicare
Yeah.
or
It's
100% of
still the
Medicaid.
gap between insurance and private insurance and Medicaid, of course, but
Mhm.
it helps narrow that gap. But in a practice our size, I change my payer mix by 1%. Either way, that's $85,000, $90,000 to the good or bad, depending which 1% that goes.
Yeah. And it seems like you have followed what a lot of people in the podcast describe the dyad, where you have strong physician ownership and leadership, and then a very strong mission driven administrator. And you follow that across the practice and CPP.
Yeah, we try to make sure that physicians are involved in leadership, and having a physician-led organization is very important. But having those strong administrators who stay with you is even more important. There's multi-specialty super group here in town called COPC, Central Ohio Primary Care. And they have family practice internal medicine, but a lot of pediatric practices have joined. And one of the most common reason that practices join that huge group is because they lose that strong administrator, and they either can't find anyone to replace them, or they want to take the energy to train somebody new. And it's just an easy fix to just be absorbed as part of this larger organization and let that organization do the administration.
Are they happy?
Yeah, I think for the most part, they're happy. Their unhappiness is not great. They complain about having to give up control and things like that, but they're still allowed to for the most part, practice medicine as they see fit.
That's what the systems usually do to a practice. They'll just go over and they'll say to them that, doctor, let us take care of the business of medicine. You do what you do best. See the patient, stay in the room.
Mhm.
Don't come out.
And this COPC is a physician-driven organization. That is a good thing about it. And I think that's why most physicians are still happy with it, that progress. And that group, as well as our group, is very much don't join a hospital
Yeah.
system.
Yeah. So what I'm hearing here as a recurring theme, the word physician led.
Mm.
I think that's what makes it a successful project. When you start to have MBA suits led or private equity led, where everything is the dollar sign, and I really don't care about the MD, I think that's where the problems come about.
When I was a third-year medical student, I had a psychiatry professor who's kind of a cantankerous soul, but he said during one of our rounds, he just sat down and he said, it should be the goal of every young physician to go into medical administration, because if you don't, someone else will and make your life miserable.
Oh my God, that guy was a genius.
It-
That guy predicted the future.
He did. He was 20 years a family practitioner before he decided to become a psychiatrist. And then
Right.
he's the professor at my medical school. But
Yeah.
yeah, I'll never forget that.
And, right before this podcast, I just finished an interview with a physician. We were looking for a physician for our practice to join us. So, if anybody out there in the podcast land is looking for a job in pediatrics in nice Long Island, reach out to me. Worked for 10 years at a system at a big place.
Hmm.
She used to work in a private organization, and then something happened in that organization, some illness or something, and went to the system. Now she wants to leave the system because she's not happy, not because of the money, not because she's just unhappy.
Mm.
Lots of clicking, unnecessary things. And she seemed to have liked it in our office. I don't know. We'll find out. The doctors
Oh, that's good.
there.
And while I remember my psychiatry professor's admonition, I am grateful for all the non-physician administrators that I have with me. I think they do a great job. And there's several that have mentored me as well, at least in practice. I can't say that's happened in the hospital side, but
Right.
we had some strong leadership in the practice to begin with. And I think that helped
Did
me
you do any
grow.
formal extracurricular training like an MBA or
Not a degree. I've done a medical leadership course,
yeah,
which our
or
local
important?
hospital offers. And I've done a quality improvement course through the local hospital as well,
Yeah.
but
Yeah.
nothing. And I read on my own, but I've not done
Yeah,
any.
I did an online MBA 2 years
Oh,
ago.
yeah.
I did it more for I think I knew everything about the stuff. It was you learned it in the office. Every
Yeah.
single project was roundabout from the office. I did it more for validity, I think,
Hmm.
and it gives you a little bit of influence, I believe.
Yeah, I think you're right.
When you're talking to other people, I was told by some business people, do you know what MD stands for?
So
Money dumb. That's terrible. That's how the business world looks at doctors. MD means money dumb.
It seems like you have a pretty good relationship with your children's hospital.
That's important.
we do. I would say the majority of us who practice in town trained here. And overall, the work I do for the hospital is actually to help maintain and enhance the relationship between the hospital and the community physicians. They've actually hired me, and I have 3 other coworkers who are in practice, and that's our job. to you know, put out fires, or if there's complaints from the community or concerns from the community. And also if the hospital's doing something that might infringe on the community pediatricians' business, they consult with us before they do anything. So it's a pretty good working relationship.
What sounds the recurrent theme that I'm hearing here is relationships with the hospital and the community, not an adversarial relationship. That's a good thing. That's the way it used to be. It's good that it's continuing in your neck of the
Yeah, I think overall the hospital does a good job of not only being a large tertiary care institution, but continuing to be a community hospital. Actually, years ago, the university wanted to move our children's hospital up to the university campus because that's where the teaching program for the Department of Pediatrics was. And it was the community physicians who were attending. This is back before I came here. It was in the 70s. The community physician says, no, you're keeping the children's hospital here. We will take care of teaching, and we will take care of helping teach the residents as well as the medical students. And the university backed off, and you have a large freestanding children's hospital still.
Is that what we're seeing in today's world, Dr. Bravo? You're big on this topic.
I think these community children's hospitals are the best hospitals around.
Yeah.
They don't have fellow and a super fellow and a senior resident and a student attending in some lab doing research. You can't get a hold of them.
Yeah.
But it's tough because so many of the kids are on Medicaid that this children's hospitals take it on the chin.
Yeah.
They just can't manage the volume, and the community hospitals are all getting out of pediatrics.
Yep.
It's true.
And there's just not, it's great to have efficiency. It's great to have expertise. One place can't handle everybody's patients at once. And I really fear, Dr. Offit talks about a measles epidemic. I fear that if there's another H1N1 influenza pandemic, which there will be, which hits predominantly the kids, we don't have the resources to take care of them. The pediatric emergency rooms in the community are gone. The pediatric wards in the community hospitals are gone. Most practices their schedule is full. They couldn't take another 40 patients. And the children's hospitals are up to capacity. And the children's ERs around the country are, this is a terrible word, but they're burdened with mental health, trying to get a bed for somebody that's having a mental health crisis, and they can't move them. And God forbid we had something in that scale like we did in 2000, because we don't have the infrastructure anymore. We've done away with that.
Yeah.
Bill, how do you measure what's important to you as a leader in the practice?
The first thing to me is, am I creating a culture that is a culture that people want to work here and want to practice medicine here? And I always measure how am I doing in that, creating a culture, not just by doing things to make sure this is a good place to work, but the things I'm doing day to day, how I talk to people, how I react to situations. And I'm always looking at that to see if I can do better, or if I'll pat myself on the back if I think I'm doing a good job. So the culture, creating that culture in the practice, I think, is the first and foremost thing. Is the practice are we still being effective? Are we still making money and completing our mission? And I always reflect on that at the end of every week. Are people getting recognition when they deserve recognition, not just admonishment when they are not doing as well? So I try to make sure we do that. And I try to make sure I'm measuring how well I'm doing there. So
Well, it sounds like you guys got rid of that military medical hierarchy.
Yeah.
General, captain, lieutenant,
Yeah. We try to,
and then senior resident, chief resident, junior resident.
Yeah. Yeah. We try to do a team approach. As far as the positions, all our owners are equal, and you work with the team. I send out a message every month to the entire practice, every owner and every employee, and I address them as fellow caregivers, because if you're not providing direct care to a patient or family, you're helping someone else provide direct care to a patient or family. So that's how I address the employees in my monthly message as fellow caregivers.
Yeah.
Right.
And how do you physically measure the results? You do like patient satisfaction surveys like you do in
Yeah,
a hospital or
we do have, and I think some other groups use this. We use Phreesia as our online check-in. So with our online check-in, we can get patient feedback. We also regularly do feedback from our teams, our staff, particularly the nursing staff, as far as what's working, what's not working.
okay.
You spend a lot of time in culture.
Yeah.
Yeah.
Who
Try to.
spends the time in finance? The COO?
Yeah, we have someone right now. He's part time, and that was part of our restructure when we went from being a small to bigger group. We realized we needed someone to just handle that, and he does all the spreadsheets and looks at our expenses. And our executive director, who is so that guy is our CFO, and then our executive director is essentially our COO. She also basically runs the operations, but looks at the overhead and says where we can, maybe cut some corners or not, at least take some off of the bottom line. So or some off of our overhead. So the bottom line's better. But so that process, that division of labor has worked out well. But I look at that stuff too, but I see them as guiding me and helping me achieve those goals.
Yeah, we never asked you, what EHR do you use or practice management system do you use?
So we're currently looking for a new system. We're currently using on Greenway Prime Suite.
Oh,
Yeah. So we're looking, I think, George, you were on OP. Is that correct?
there's two products. Don't look anywhere else. Either
Yeah.
Office Practicum or PCC.
Yeah.
Don't look anywhere else.
So we're looking at, actually, we're talking with OP as far as coming together in a larger group. So OP is definitely one of our top choices. The other choice that, and again, it's just would be to be part of the bigger system is Epic. I don't think any pediatrician likes Epic. That's what everyone's trained in. That's what everyone coming out
That's
of
the hospital.
residency.
The outpatient module is different
Yeah.
and you cannot function. You will not, they function, but it'll be a lot of collateral damage.
Mm, mhm.
We went emergently from an EHR that went out of business and we went live in 2 weeks and
Mm.
it was no collateral damage at all.
Right.
Office Practicum, very good product.
Yeah.
PCC is a very good product also. They have a great practice management. They have a great EHR nowadays. It depends on how much hand holding you need. So I would not look anywhere else. Just those two products. There's no other choice.
Thanks. We're definitely, I think, honing in more on OP just because we can use Phreesia for right now. I think OP is going to put in some things that we can get rid of Phreesia at some
Yeah.
point in time.
We should integrate. We use Phreesia also with them. I don't like being a guinea pig for EHR companies. So I let them figure it out. And then a year later, after they get
Yeah.
the bugs out, then I'll take their module if it works. If not,
Not a beta tester then, right?
not anymore. It's the operation's too big
Yeah.
for clunkiness. But Phreesia is a good product, let me tell you.
Yeah. We like it. We've initiated self-scheduling with that. We just started that this year and we're putting all our flu clinics as self-scheduling on Phreesia.
That's good. What do? They do a schedule to a form or schedule directly into the EHR.
They schedule directly into the EHR.
Also, they have the interface with that. Yeah, I don't think they have that with OP. I wish they would. OP, I wish you would get the interface with Phreesia for direct scheduling, but what am I to say?
Bill, for
So
a
far,
young
direct scheduling's working out. So we're moving.
Yeah, and it's the way of the future. It's people that they
That convenience factor that Herb talked
don't
about,
want to, they don't want to make a phone call.
right? They can get their kid in the car and be at the urgent care before they're off the phone, off hold even.
yes,
Part of the
yes,
problem.
yes. And I don't know how it is in Ohio, but we in the urgent care, we did appointments online and they ran 24 hours, 7 days a week. And so you could be at 10 in the morning, you're in the middle of the meeting and you get the call, Johnny's got a fever, you need to pick him up. And by noon, the pediatrician's offices were full. That's just the way it is. And you're like, what do I do? Do I reschedule all my appointments for tomorrow? Or what am I going to do? And that creates a lot of anxiety in the parents. So they could log in, put all of their demographics, their insurance, their medical history, and it would give them a time that we would be able to see them in the evenings.
Mhm.
And people loved it. People just loved it. My colleagues were always scared, like, what if it's a meningitis kid?
Yeah.
I'm like, I'm not saying meningitis kid. The parent might wait until 7 o'clock at night to bring him to the urgent care because he's got business meetings till 6 o'clock.
Yeah.
I have no control over that, you
Yeah.
know? So
Yeah. What I found with the self-scheduling, I've been a proponent of self-scheduling for many years. It's just that the EHR companies, they don't want to do it, cannot do it, or they think that the physicians don't want it. And I did notice that one of the biggest roadblocks is self-scheduling, whatever version it is the physician himself. They don't,
Right.
they want to feel that somebody's controlling their schedule.
Mhm.
And what if she puts in a checkup where it should be a sore throat and it'll mess up it short circuits the doctor's brain somehow. But years ago, we used to use this, which I thought was the best product I've ever seen in my life, Concierge MD. It was this little product. It was a third-party portal that connected with the EHR and the practice management. They could see what the schedule is like. They could book their appointment, give you some information about a fever, book your appointment with me tomorrow at 9 o'clock. And they just show up into the EHR. Of course, they got taken over by a big company and they killed the product, sunset it, and put it in a vault. That's the story of life. But we had some difficulty once we got it off the ground through the portal. Like I said, the biggest problem was a lot of the doctors.
Yeah.
Half of them would accept it, half of them wouldn't.
Mhm.
Just like with anything.
Yeah.
Uh, Bill?
That's what we're trying to go slow to show people that their day is not going to be ruined by self-scheduling patients.
Yeah.
And then a group of us are trying to schedule the ill visits, and we'll see how that goes.
Yeah.
Yeah.
But do it at restaurants for reservations.
Oh yeah.
It
Everybody
works
does it.
well. Open table there. I was like last week, I was in Italy on a vacation. You could not make an appointment without an online scheduler on Open Table or something. I want to go to this one place. I said, let's go there to make the reservation for tomorrow. They said, we can't do that here. You have to do it online. I logged in online on my phone in the restaurant
While you're in the restaurant.
to make a reservation for tomorrow.
And the airlines now charge you if you call the attendant. If we get a
What?
person on the phone, the airlines will charge you extra.
Yeah.
Yeah. An airline booking is much more complex
Yeah.
than scheduling your kid's well child exam.
Yeah.
It is much more complex. Bill, if you're mentoring young pediatricians, what advice on leadership and management would you give them?
I would tell them to get involved with something besides seeing patients early. Whatever that is, whether if advocacy is your thing or leadership or management, to do something to become a leader in some aspect. I think that's not only good for a physician to do something besides see patients, but it's also good, as we discussed, for organizations to be physician led. And don't wait to get your feet wet in practice. You can start small, but do it early, so
Yeah.
you get used to that balance, and you can be involved early because, a lot of these people coming, I mean, you can't get into medical school now unless you can prove you're a person who wants to make the world a better place. Right. And I think, these younger new physicians aren't ready and eager and don't want to see their, hopes and dreams of leadership and advocacy squashed by a 40 patient day every 5 days a week, things like that. So I'd encourage you before that practice builds up to start right away, even as just a few hours a week.
That's great advice.
That's great advice. Yes.
Thank you so much for sharing time with us. Are you going to be coming to NCE?
Yeah, I'll be there.
We look
Going
forward
to
to
the-
seeing you there
We'll
then.
be there also.
Great. Yeah.
Yeah, it'd be nice to see you there.
CPP will be there as well. We're going to have a dinner, I think, on Monday night. We're good to see you guys there.
Yeah, we'll stop by
Okay.
and we'll chit chat. And maybe
Great.
Herb will go, whatever past guests we had, we could say hello to them and make a podcast of past guest.
Oh yeah. Okay.
Pretty cool thing.
Be fun.
Sounds great. Now
All
stay well.
right.
Thank you for your time. This has been delightful.
Sure. Thanks for having me.
All right. Take
Take
care.
care. Bye-bye.
I hope you have enjoyed this episode. In October, we will all be having the pleasure of seeing each other at NCE 2023 in DC. As you know, Dr. Wania, Dr. Rogu, Dr. Birch, and I meet every Tuesday morning in the Pediatric Executive Development System, or PEDS, which is a dynamic transformative program designed to accelerate the growth and development of leaders in the field of pediatric medicine. We use our PEDS Dash to inform pediatric leaders of the opportunities ahead of them so they can turn data into insight, into action, and into profits. When you are at NCE, please do not forget to visit my good friends from Nicholas Children's Hospital in Miami. They will have a booth there. As you know, I love the postgraduate course, now number 59th, that is held every March in Miami Beach. I will be attending the 59th postgraduate program in Miami Beach 2024. Stop by Nichols Children's table at NCE and inform yourself about the 59th postgraduate program in Miami Beach, March 2024. PCC sponsors this podcast. The Physician Computer Company at pcc.com is a very generous sponsor of this podcast, so please do not forget to visit their booth at NCE AAP DC 2023. Again, do not forget to stop by and say to Chip Hart and the team from PCC at the National Conference in DC. George and I hope to see you there.